First, thank you, Lynn, for joining me. It's great meeting you. I followed you on LinkedIn, and then I want to hear everything about you.
Sure. So I'm Lynne Gauthier. I'm a rehab psychologist, and I did many years of research. So I started in an academic setting, but an academic medical setting as well. So I was in an outpatient neuro rehab clinic, working closely in conjunction with OTs and PTs there, as well as running my own research program. And the focus of my research was really to make these evidence-based interventions accessible to people on a wider scale, because we knew that our neuro folks just were not able to get enough rehab to get where they could be. So in my research, we were looking at using technology as a way to bridge that gap and make it accessible to people in their own homes. So it changed the role of the therapist a little bit. And we started out studying this model, which now has kind of conveniently morphed into RTM. So we were actually researching RTM before RTM even existed. So have been in this space for a while. And I trained with Ed Taub down at UAB, and he's the inventor of constraint-induced movement therapy, did all the research on it. So that's how I kind of came to be in the PT space and work closely in conjunction with PTs and OTs, starting out in the neuro space and since expanding into other kind of chronic conditions as well, like back pain, knee pain. So really I see RTM as a great way for chronic condition management and managing conditions that take more than just a few hours in the clinic. It's a way to keep patients engaged for longer periods of time and to prevent that backslide. Because when you're managing someone with a chronic condition, whether it's stroke or whether it's patellofemoral pain, which I have, whether it's pelvic floor issues, which I have since I had twins, all these things require that you get brush up PT just continuously to maintain your function. Wow. And that's challenging for the patient, right? It's hard for them to find the time in their busy lives to come in, or if they can't drive, then they have to rely on somebody else to transport them. So a lot of what we do is kind of meeting the need for the accessibility piece, as well as the intensity of practice piece, so that patients can really get the amount of therapy that they need to get well and stay well.
Yeah. So what's the name of the platform? And then give me some idea or understanding. I looked at some of the videos. I commented on one of the videos that you shared. I love the real patients using a real product approach to what you're putting out there. What's the name of the platform, and give us a little more context around what it is like?
Yeah, so our platform is called RxGames, and it rolled directly out of our research. So we started way back when using the Microsoft Kinect sensor, but this wasn't able to get it to the masses. So after we did the research and clinically validated that, hey, this RTM model works, we can get better outcomes for patients. Then we started a real push to get it onto mobile devices that people already own. So in this way, a rehab practice can they can push out a prescription to a patient, and then the patient can do the rehab gaming on their cell phone, on their tablet, on their laptop computer. So that way we can, they can use it with all their patients and really drive treatment forward that way.
Yeah. And so you had mentioned neuro. This started as a primarily neuro-based intervention. Then it's progressed into orthopedic. But from a neuro perspective, is this, I'm not a neurotherapist, but I know a lot who are. Give me a little more context. Is this somebody who's had a stroke, somebody who's had a brain injury, or are there any like conditions that are more appropriate than others?
Yeah, I would say all of the above. We really designed our platform to be disability friendly exercise, and it's purpose built to progress the exercise based on the level of ability of the person. So pretty much any neuro population, we worked a lot of our clinical trials are in stroke. We've also worked a lot with MS and TBI. We have a whole Parkinson's disease rehab program that's based on the LSVT big kind of principles. So really getting the person to exaggerate, do larger movements, quicker movements. So that's our neuro offering. We have upper and lower extremity for that. And then we've worked with the military to build out some other things more in the ortho space that you're in. So for like patellofemoral pain, back pain, ankle injuries are also common. So different exercises to stabilize the ankle. And I would say some of our games can be used across neuro and ortho applications because some of the exercises are the same. For an ortho application, people are probably doing it at a higher difficulty level than for a neuro application, but it may be the same exercise. Sit to stand is applicable on a wide range of patients, for example. So a lot of these exercises are just exercises therapists commonly use with patients, and then we built in difficulty progressions within each game and exercise.
Now I'm curious because thinking about these kinds of conditions, they're long-term, usually degenerative conditions or stable. They're not getting better, not getting worse. Do you see that clinicians are maybe using this during an active plan of care, but then when a Medicare plan of care is complete, the patient's discharged from covered services, they would continue to use a platform like this as long-term continuity?
Yeah, that's ideally what we're positioned to do. So we can help in two ways. One is during that acute bout of care, because adherence to home exercises is a problem.
Sure.
I mean, every therapist knows that people don't do what you ask them to do, even when they want to, and they want that accountability. So RTM is a way to provide that accountability and get it billed through insurance.
Right.
So our platform is basically the technology that the therapist can see how much the patient is engaging with each exercise and look at their range of motion and look at how that's progressing. So these things can be helpful during treatment, mainly as a home program when they're not directly with the therapist, or for an inpatient setting when, nights, weekends, just as a treatment multiplier when they're not directly working with their therapist. So the therapist, once they learn the program and they know how to move within the games, they've mastered it. And that usually takes 15 to 30 minutes. And then they can do it independently. So that's how we've designed it. Most patients, after their discharge, they then want to keep up with their therapy. Usually not as intensively, but they want to maintain what they've gained. And some folks really like to use it as exercise as well, because in the neuro population especially, it's really, or anyone with a disability, it's oftentimes hard for them to access exercise spaces like gyms. So they see this as a way for just general wellness, not necessarily, I need to make my arm range of motion better, but I want to be moving my body. I want to be keeping up with my cardiovascular fitness and health. And they can use it, they kind of shift how they use it over time. And
let me ask you, do you see any of your clients, the therapists that are, once the Medicare covered services are done, they're charging a monthly rate to clients to continue to have access to the platform?
So our model is they don't typically charge clients, though each business can do that if they want to. Some businesses don't work through insurance and they may want to do it like through a self-pay model, in which case they could do it that way. We typically engage with the clinics, and then the clinics oftentimes will offer it as a service as part of their treatment plan to the patient. It doesn't usually cost the patient to do it.
I'm just thinking, I know so many clinicians that as, plans of care, covered services are getting shorter, as reimbursements going down, they're looking for opportunities to improve the quality of the patient care experience and monetize other aspects. So when I look at RTM, I look at it beyond just the third-party reimbursement. I'm like, a platform like this, it just makes total sense. If I was looking at it, I would include maybe a fee for the a phone call, a video call, something that would be resemblance to telehealth. We know for Medicare at the end of 2024, telehealth is probably no longer going to be covered, but that doesn't mean that we have to stop. We can continue to sell it as a self-pay service. So packaging your service with some sort of continuity program that includes a telehealth component, whether it be video or audio only on a call, maybe an occasional visit to the clinic if a therapist has a clinic, or a mobile therapist who wants to do this in the home. I just see so many opportunities for something like that, taking it beyond maybe what people have been doing. Let me ask you, because you mentioned adherence, you mentioned a couple of things. What are some of the challenges? You've been at this a long time. What are some of the challenges you're seeing therapists deal with when either the practice owner says, hey, I want to start doing this, you guys are going to come along for the ride, or just in general, what are the barriers, the challenges? Because this is something new, it's something different that we're not used to. What are you seeing?
I think with anything, it's just getting used to something new. And a lot of therapists are just are not super eager to adopt technology in general because they've been kind of jaded with it in the past. So it needs to be really, really easy to use. And when we designed it, that was first and foremost on the front of our mind, because if it takes more than a minute to set something up for a patient, they're not going to do it.
Right.
It'll just get put in a back room somewhere. And, I've gone into clinics so many times where it's like, oh, we have all these expensive pieces of equipment and they're in a room and the patients never see any of it. So we didn't want to be that. We wanted to be something that would be used on the majority of patients as part of a treatment model of care. So when we designed our web portal, that was one thing that we wanted it to be super easy. I mean, you can make a prescription for a patient in less than a minute. And get them started. And then they just download it from the App Store. So it's a relatively easy setup. There's no calibrations. There's no tech that has to go on a person. The second you start getting into, we got to calibrate this thing on your arm, forget it. Even in the research, that was challenging for us. So that was never going to make it into a clinic.
Yeah. Have you found any like simple tips that we could share? Because I know clinicians, even for me, it's always a challenge if I have to get an app on a device for a client. One of the things that I try to do is I just make it part of one of the treatments. So if the client's in my clinic or a mobile therapist is at the client's home, part of the therapy session today is we're going to set this all up. So the app is installed, everything is running, you know exactly how it's used. Are therapists doing that, or do you have any tips for therapists who want to roll something like this out?
Yeah, I would say, use the other staff that are available to you. So if you've got aides or a PTA or someone that may not be quite as, pulled in many different directions as the therapist themselves, then that could be part of when the patient is onboarding, it's that person just helping them get it on their device.
Yeah.
And supervising that part. That way the therapist, it's already there for the therapist, and all they have to do is use the web portal and make the prescription and push it out, that's pretty easy for the therapist to do. The challenges more come in when you have a patient that's not super, tech savvy, doesn't know how to download an app, for example, or doesn't know how to access their email or connect to the internet, to get it set up. So those are kinds of things that they're not huge. You don't need like an IT person to do those, but someone who just is tech competent. And that can take effort away from, that takes that burden off of the therapist. So that's the biggest thing, is just having point people to just do that part of it so that you're freeing up your therapist's time for the stuff that they want to be doing.
Right. And so now I'm going to show my ignorance on the whole topic, and I want to get into a little bit of the framework. My limited understanding is for certain codes within RTM, there needs to be 16 interactions within a 30-day period, or 16 and 30 days. So within your platform, is that something that's tracked by you guys, and then the physical therapist is notified, or how does that work?
Yeah, it doesn't have to be 16 interactions. So you don't have to have 16 calls with the patient or text messages with the patient. That would be completely not feasible for any clinician to do. It needs to be collecting data for at least 16 days of each month.
Okay.
So, and that is just adherence. It can be just adherence data. So our platform, it's automatically collecting the data when the person logs on and uses it. So it's constantly collecting data because it's on their device. So you get data for 30 days, and they don't really have to worry about that aspect of it. The other thing that is required to bill for RTM is that at least once per month, a 20-minute consult. So like what you were talking about with, having those brush up sessions, that's part of RTM. You can't do RTM without speaking with the patient at least once a month. And that's a billable thing. It's about the same payment as, if you saw the patient in the clinic, it's about the same pay rate. So it's essentially an extra visit that can be done via phone or via video call. And that's in conjunction. You bill the two things in conjunction with one another. So you can't bill to just monitor data.
What's the time requirement for that call?
20 minutes.
Okay.
20 minutes once a month. You can do it more than once a month, but that's a minimum. There has to be a 20-minute call where you go over the data with the patient. I think from my research, what's really helpful to do during that call is a lot of the behavior change stuff to help them carry over what they're doing in the clinic to their everyday environment. So yes, you'd log on, you'd say, hey, looks like you've been playing RxGames 3 times a week for X amount of time. That's great, keep it up. Or weekends seem to be kind of hard for you. What's going on the weekend? So you can do some problem solving. What ideas do you have to increase the amount of time you do this? Let's try to hit the exercise recommendation. Let's try to get you to 150 minutes per week of exercise. So they can do those behavior change pieces with the person, help the client come up with their own ideas of how to improve adherence and improve their carryover. And then we also, in our research, spent quite a bit of time on specifically asking about their everyday activities. So we don't want to just have them do a game and that gets them stronger, right? It builds strength, it builds endurance, but it doesn't necessarily help them cook a meal.
Right.
So we want to take that RTM time and make the connection between the physical exercises that they're doing and how that's translating into what they're doing in their everyday life. Right. So during those RTM visits, you can also ask about, you've been working your arm in this way in the game. Tell me what you've been doing with your arm day to day. You could list out some different activities that would use a similar movement. Tell me how you've been using it for this. And oftentimes people aren't doing day to day what they're capable of doing. So that's a great time to problem solve around some of that. You're able to you're able to do shoulder abduction and get your arm up to here. Are you turning on light switches with that hand? Like based on what I see of your movement, you're certainly able to do that. What do you think about adding that in? And then their whole life becomes maintaining and improving.
Yeah, it's so funny how patients don't always make that connection. I was in the clinic this morning working with a patient who had a knee replacement. We're on a recumbent bike. She's measuring well past 90 degrees of flexion, but then as soon as we get off the bike and start walking, she will not let the leg bend. She won't bend the knee. And I'm like, look, you realize you just were at past 90 degrees and now you're not even moving through 10 degrees of flexion. And she's like, oh, I didn't even realize it. Let me ask you, going back to the 20-minute threshold, is that something that has to be done on a single call, or could that be broken up across multiple calls within the time frame?
I think it's a single because it's like you bill it as a unit.
Okay.
So like with the other therapy codes is per 15 minutes. This is a 20-minute unit consult. You could do it more than once. So you could do 40 minutes in a month and bill twice. So there's actually different codes for the first 20 minutes and then subsequent 20 minutes.
Yeah. And I'm sure you probably won't have an answer for this, but I'll research it. I can't imagine that call how do I say it right? I can't imagine you could double dip in the sense of billing a CPT procedure code if it's a video and audio call, like I would do telehealth for a Medicare beneficiary. And if it's about that RTM, I don't think you could probably bill both. Like
no, and I don't think you do them on the same day either.
Yeah.
So I think you would want just therapeutically, you wouldn't want to do that,
Sure.
right? Like, you're better off having more interactions for shorter periods of time. You're going to get a better result than if you treat them for 2 hours straight. More is going to get through, especially from a habit change. You're working on that carryover bit. They got to think about things a little bit. They got to start implementing them. So the more times you can review that with them, then it's going to be more effective. So I would say definitely you can't double dip with it. And then you can't do it on the same day, nor would you want to.
Yeah. Yeah. Let me ask you, as we kind of wrap things up, what has been your experience? And I know you can't speak for everyone and everywhere, but I'm trying to get a sense for, okay, we know Medicare is covering RTM. What about any of the other big 5 third-party payers like Blue Cross, Humana, United? What has been your experience so far in general?
We're still learning all that, and I'm not providing the therapy, so I don't have access to what who other people are billing. In general, if Medicare is offering it, they all adopt what Medicare is doing.
Right.
Because that sort of sets the standard for what those codes are. So I believe all the big insurers are doing it. It's certainly in their best interest to do it, because the research is very much in support of that. And it's a cost effective. You can, PT in general is cost effective.
Yeah.
And then when you do it with short bouts of RTM, that's cheaper than them having to come in for a full 45 minutes or 1 hour. So it wouldn't make much sense for them to restrict it, but I can't speak for every insurer.
Yeah. And obviously I'm a physical therapist, so everything I talk about is physical therapy, but I would imagine occupational therapists, are you guys working with occupational therapy also? Do you have anything available for speech, or is this something that your platform is primarily PTOT?
Our platform is more for the physical side of it. So PTOT and exercise, cardiovascular. A lot of our games have a cardio component too, so it could be used for cardio rehab. Speech, no. And cognition, some OTs use it off label for that, because there's some dual tasking and task switching and processing speed kind of built into some of the games. They can be quite cognitively challenging, some of them. But we don't have anything for speech specifically. However, speech therapists can use a different product and bill for RTM. So they are eligible under that allied health professions that can bill RTM, as well as nurse practitioners and physician assistant.
Wow, that's awesome. Well, I want to be respectful of your time. For people who are watching this, who want to connect, want to learn more, what's the best way for them to either go to your website or connect with you directly?
So you can connect with me on LinkedIn. We have a RxGames page on LinkedIn that you can follow, and our website is www.rxgames.com.
That's awesome. Don't go anywhere. I'm going to end the recording, but I just want to take a minute and say again, thank you so much. I know we just met and kind of rushed this interview out, but I think we got some really good information out to people who could benefit from it. So thank you.
You're welcome. It's great chatting.